Good morning, everyone. Welcome to Grand Rounds. Today is a special Grand Rounds presentation where we will have two of our second-year residents who participated in our resident research block sharing the work that they accomplished during these blocks. They were selected from a group of nearly 40 residents who presented at our resident research symposium. They're among the 4 residents selected to present their work here at Department of Medicine Grand Rounds. It's my great pleasure this morning to first introduce Dr. Revathy Sampath-Kumar. Dr. Sampath-Kumar received her undergraduate degree here at UCSD in biomedical engineering, graduating cum laude. She then completed her Doctor of Medicine training at Wake Forest School of Medicine in Winston-Salem, North Carolina, where she was awarded Best Overall Performance in Internal Medicine. We were very fortunate to recruit her here to our internal medicine residency program at UCSD, where she's been a member of our resident as clinician educator pathway and an outstanding physician. She'll be presenting her research to us today on inferior vena cava diameter independently predicts acute decompensated heart failure rehospitalizations. Thank you so much, Dr. Sampath-Kumar.
Thank you for that introduction, Dr. Dassel. So kind of you. I'm very honored to be presenting to you all today. I conducted research with my mentor, Dr. Ben Yehuda, on a novel approach to heart failure management using ultrasound inferior vena cava diameter measurement, which we found to be an independent predictor of acute decompensated heart failure rehospitalization. I'm going to start with an overview of the presentation. I'll start by discussing the background and significance related to the project, then go into methods, followed by results, ultimately conclusions, and then go into clinical utility, as well as the next steps for this study, which is our prospective study. So there's a high prevalence as well as incidence of heart failure, and this continues to rise. Currently, 6 million people in the United States alone have heart failure. By 2030, it is projected to rise by 46%, affecting more than 8 million people in the United States alone. The graph shown on the bottom right depicts this separated by men and women. And the table on the left shows that in 2014, the total incidence of heart failure was 1 million. This is estimated to be around 6 to 7.9 per 1,000 person years in those greater than age 45, and 21 per 1,000 person year after the age 65. With this comes a significant cost burden, currently $30.7 billion and rising, and projected to be nearly $70 billion by the year 2030, as shown in this graph, separated by direct and indirect medical cost, with $11.3 billion due to the cost of heart failure hospitalizations alone. Heart failure is also the leading cause of hospitalization among older adults and Medicare beneficiaries, and those with heart failure have the highest readmission rates of any other medical condition, as shown in the graph on the bottom right. Rehospitalization rates vary pretty broadly from study to study, some reporting over a 50% rehospitalization rate within 30 days. This study from JACC that I've shown on the left has a readmission rate over 5 years of around 40 to 48%, and they also found a significantly less rehospitalization rate in patients with preserved ejection fraction. But again, this varies from study to study and from hospital system to hospital system. What is known for sure is that there is a high mortality associated with a heart failure diagnosis. There is actually a 75% 5-year mortality in heart failure patients, regardless of left ventricular ejection fraction, as shown in the graph on the left. And the number of heart failure hospitalizations has actually been shown to stratify the risk of death, as shown in this graph from Lee et al. On the right. Patients with greater than 2 hospitalizations in the preceding year had significantly decreased survival compared to those with 1 and 0 hospitalizations in the previous year. Thus, preventing rehospitalizations for heart failure could not only reduce medical cost, but also improve patient outcomes. So the question becomes, why are patients with heart failure hospitalized and rehospitalized? 90% of acute decompensated heart failure admissions are due to volume overload rather than low cardiac output. The European Society of Cardiology actually released a scientific statement on this and also gave some tips for how to grade congestion, as grading congestion would be helpful for both initiating and following the response to therapy. But right now, there has been no validated clinical assessment of congestion, and it has not been used systematically in the clinical setting. So accurate volume status determination in heart failure patients is crucial to direct medical management, but there are several challenges with our existing volume status measures. I'll start off with discussing physical exam findings such as RALs, jugular venous pressure, and edema. These are commonly used in the inpatient setting and really the mainstays of volume status determination. But there are several challenges, including inter-observer variation, and also several studies have found that patients have ultrasound indices of elevated intravascular congestion in the absence of these signs. Body weight trends are also frequently used, but they're difficult to interpret as patients may gain non-fluid weight or lose skeletal muscle mass over time. And daily weights in the hospital setting are definitely prone to error. It's hard to ensure that all of the weights are standing weights, and there is variation from scale to scale, and they're often not done on time. More recently, natriuretic peptides, specifically BNP and N-terminal proBNP, have gained utility. They have been shown to rise in acute decompensated heart failure and do relate to disease severity, but they are not specific to heart failure and are influenced by other factors such as age, body mass index, etc. And further, it has been shown that BNP does not correlate with hemodynamic measures of congestion, specifically in acute decompensated heart failure. On the top right, you can see a CardioMEMS device, and this is produced by the company Abbott, and essentially a method of invasive pulmonary artery pressure-guided heart failure management. Studies have shown that this actually reduces rehospitalization and mortality in patients with reduced ejection fraction on guideline-directed medical therapy, but this does require an implant and is expensive, and only a small fraction of patients have this device currently. Pulmonary arterial pressure-guided heart failure management in the inpatient setting, shown by the Swan-Ganz catheter in the bottom right, failed to show benefit over clinical assessment in heart failure patients and actually had increased rate of risk related to the procedure. IVC diameter may be an alternate, more effective measure of volume status, and I'll explain why. It really starts with the pathophysiology of congestion, which begins with fluid accumulation and redistribution, which precedes filling pressure increases, symptoms, and weight gain. Non-invasive hemodynamic monitoring using ultrasound inferior vena cava diameter may be a more sensitive and direct measure of intravascular volume, which would allow us to catch patients in the fluid accumulation stage, preserve the venous capacitance buffer system, and prevent hospitalizations. This figure illustrates human IVC geometry. This is a study done by Seo et al. And on the x-axis, you can see the short to long axis ratio. And on the y-axis, you can see central venous pressure. As intravascular volume initially increases, there's a considerable shape change of the IVC from elliptical to circular with a minimal associated pressure change. During this period, there is a large change in volume with minimal change in pressure, and IVC diameter may be more reflective of volume status. IVC diameter is actually measured by transthoracic echocardiography, and this is specifically from the guidelines of the Journal of the American Society of Echocardiography on evaluating the right heart. So in order to measure the IVC, you want to be in the subcostal view at the long axis at end expiration. And you want to make sure that the patient is not doing the Valsalva, as that would actually increase the IVC diameter that you're measuring. You take the measurement just proximal to the junction of the hepatic veins that actually lie 0.5 to 3 centimeters proximal to the ostium of the right atrium. Several previous studies have demonstrated reproducible IVC image acquisition by healthcare providers at various levels of training with very limited ultrasound training prior to doing this. There are very limited studies on the actual utility of IVC diameter assessment in heart failure patients, as well as relationships to clinical variables. Most of the pre-existing studies are in outpatients with chronic heart failure and only had 1 to 3 months follow-up. We therefore sought to collect a large sample size of inpatients with acute decompensated heart failure with up to 1 year follow-up. Going into the overall study design. So I conducted retrospective chart review for 200 patients admitted to UC San Diego Health Hospitals from 2018 to 2019 for a primary diagnosis of acute decompensated heart failure. I looked at those with both reduced and preserved ejection fraction who had a transthoracic echocardiogram during the index hospitalization. Patients were excluded if they required mechanical respiratory or circulatory support or an inotropic agents, those on dialysis, those with mechanical assist devices, cardiac transplant patients, or congenital heart disease patients, as studies have shown that IVC diameter may not correlate with right atrial pressures in these subsets. Patients that died during the index hospitalization were also excluded. I recorded baseline demographics, past medical history, admission and discharge weights and medications, as well as echocardiographic parameters, including IVC diameter, as recorded by the echo techs. I also took lab and physical exam findings within 24 hours of that transthoracic echocardiogram. I ultimately assessed charts for acute decompensated heart failure rehospitalization within 1 year. Table 1 shows patient characteristics. Of the 200 patients included, the mean patient age was 66 years old, with 30.5% being female. 122 of the patients had heart failure with reduced ejection fraction, and 78 patients had heart failure with preserved ejection fraction. Most patients fell into NYHA class 2 or 3 heart failure, with a mean left ventricular ejection fraction of 41%. Of these 200 patients, 144 patients were rehospitalized for acute decompensated heart failure within 1 year of index hospitalization. Patients that were rehospitalized within 1 year had significantly greater mean IVC diameter compared to those not rehospitalized. As you can see, 2.25 centimeters versus 1.9 centimeters. They also had higher NYHA functional class and the presence of tricuspid or mitral regurgitation, which is consistent with previous studies. We also found that those rehospitalized within 1 year had significantly lower hemoglobin, which has been shown as a poor prognostic indicator in heart failure and could reflect either anemia of chronic disease, renal dysfunction from chronic heart failure, or pseudoanemia from increased intravascular volume in the acute decompensation stage. Patients that were not rehospitalized were more likely to be on statins and angiotensin receptor neprilysin inhibitors. Previous studies have reported decreased heart failure hospitalization and rehospitalization rates on these medications. We didn't find any difference in N-terminal proBNP between groups. Also, no difference in net weight loss, physical exam findings, or ejection fraction between those rehospitalized within 1 year and those not rehospitalized, really highlighting the limitations of these parameters. Also not shown here, but there was no difference in age, sex, race, ethnicity, or past medical history between groups. I also looked at IVC diameter from subsequent echocardiograms that these patients had. 128 patients of the total 200 had a repeat echocardiogram within 1 year of index acute decompensated heart failure hospitalization. Interestingly, patients readmitted for acute decompensated heart failure within 1 year had significantly greater IVC diameter on these subsequent echocardiograms within 1 year of that index hospitalization, regardless of their clinical volume status at that time. This shows that any evidence of a high IVC diameter has a poor prognostic indicator. In assessing correlates of IVC diameter, both IVC diameter and IVC diameter corrected for body surface area correlated to pulmonary arterial pressure. This supports the IVC diameter as a method of non-invasive hemodynamic monitoring. But measuring volume directly using IVC diameter may actually be more effective than pressure measurement, as central venous pressure and pulmonary capillary wedge pressure actually have poor correlation with blood volume in studies, whereas changes in IVC diameter have been shown to reflect blood volume changes during hemodialysis and during blood donation. Our study also shows a significant correlation between IVC diameter and body surface area, indicating that patients may have individual dry weight IVC diameters. This actually supports a previous study, which found that patients with low and high body surface area had statistically different IVC diameter cutoffs for detecting right atrial pressure greater than 10 millimeters of mercury. Regardless, we found that uncorrected IVC diameter had a greater predictive value for rehospitalization. Interestingly, only IVC diameter corrected for body surface area correlated to log and terminal proBNP. Our findings may be explained by factors known to impact BNP, such as age, sex, renal function, and body mass. Natriuretic peptide levels are also not specific to heart failure. They may provide complementary data in clinical settings. In certain situations, when a patient might have heart failure signs and symptoms in the absence of left ventricular wall stress, N-terminal proBNP may not be elevated, and IVC diameter may be a better direct measure of cardiac filling pressures. Unlike N-terminal proBNP, we found that IVC diameter is independent of glomerular filtration rate and may quantify congestion similarly in the presence or absence of renal dysfunction. In univariable Cox regression, IVC diameter corrected for body surface area, NYHA functional class, log and terminal proBNP, tricuspid regurgitation, and mitral regurgitation predicted acute decompensated heart failure rehospitalization within 1 year. In multivariable Cox regression, using variables selected from the forwards and backwards procedures, IVC diameter, the presence of tricuspid regurgitation, and NYHA class 2 or 3 independently predicted acute decompensated heart failure rehospitalization within 1 year. Log and terminal proBNP was not a statistically significant predictor of rehospitalization in our multivariable Cox regression. Receiver operating curve for IVC diameter as a continuous variable and predicting rehospitalization within 1 year is pictured here and demonstrates an area under the curve of 0.758. We identified 2.07 centimeters as the ideal cut point by Uden index, which is the maximal sensitivity plus specificity. 2.07 centimeters was associated with a sensitivity of 76% and a specificity of 68%. Patients with IVC diameter greater than our optimal cut point of 2.07 centimeters had significantly increased acute decompensated heart failure rehospitalization within 1 year, 85.6% versus 49.3%, with a hazard ratio of 2.44. Our results are highly significant with a p-value less than 0.001. Not shown here, but patients also had significantly increased decompensated heart failure rehospitalization both at 30 days and 6 months, along with at 1 year. Ultimately, this study on inferior vena cava diameter has one of the largest sample sizes of inpatients hospitalized for acute decompensated heart failure, both reduced and preserved ejection fraction, with comprehensive consideration of covariates, and the longest follow-up time in assessing rehospitalization. Our study shows that IVC diameter may be an alternate surrogate for volume status, which independently predicts acute decompensated heart failure rehospitalization. Patients rehospitalized within 1 year had significantly greater IVC diameter during index hospitalization and all subsequent echocardiograms within that year, indicating that patients may be undertreated with subclinical intravascular volume elevation at the time of discharge, which predisposes them to rehospitalization. IVC diameter may be a cost-effective, non-invasive method to detect subclinical congestion and allow for interventions which prevent hospitalizations. We determined an optimal cutoff value for IVC diameter, which can be used to assess whether patients need ongoing diuresis or can be discharged, and identify those in need of close follow-up. IVC diameter guided heart failure management in the inpatient and outpatient setting may reduce hospitalizations and rehospitalizations, help us guide diuretic dosing, and reduce overall mortality. We are currently conducting a prospective study to further test this hypothesis. So how can we incorporate this into our daily clinical practice? With the advent of handheld portable ultrasound technology, we can incorporate IVC diameter daily, both in the inpatient and outpatient settings. In the inpatient setting specifically, we can assess IVC diameter daily in heart failure patients to assess response to our diuretics, and perhaps target management to individual dry IVC diameters. We can also treat patients with IV diuretics until their IVC diameter falls below 2.07 centimeters to reduce the risk of rehospitalizations. In the outpatient setting, we can measure IVC diameter at each cardiology clinic visit and use these measurements to adjust outpatient diuretic dosages. Eventually, patients could potentially even be taught to measure their own IVC diameters daily, similar to how they measure daily weights, and adjust their own diuretics accordingly. For example, if your IVC diameter goes up by a certain amount, double your diuretic dose. We are currently conducting a prospective study to further test this hypothesis, for which I recently got IRB approval and will soon begin enrolling patients at the Sulpizio Cardiovascular Center. I will be looking at all patients admitted for acute decompensated heart failure and assess patients based on inclusion and exclusion criteria. Patients that meet these criteria will be asked to give informed consent. Within 48 hours of admission, they will have a complete transthoracic echocardiogram performed by trained ultrasound technicians. I will also administer the Kansas City Cardiomyopathy Questionnaire at this time, which is essentially a series of questions for heart failure patients that assesses their overall symptoms and quality of life. 0 to 24 hours before these patients are discharged, they will get a limited inferior vena cava ultrasound. At this time, I will also review medical record data. And after patients are discharged at 30 days, 6 months, and 1 year, I will re-administer that same Kansas City Cardiomyopathy Questionnaire to assess how IVC diameter impacts patient quality of life, and also assess for rehospitalization up to 1 year post-discharge. After this prospective observational study, I plan to conduct a prospective interventional study to see whether IVC diameter guided heart failure management improves outcomes compared to standard of care therapy. I would like to thank you all for your attention, and a special thanks to my research mentor, Dr. Ben Yehuda, who single-handedly helped me create this project and develop every aspect of it, and also for his ongoing help with developing our prospective study. This is a 2-author study and could not have done any of this without him. I would also like to thank the UC San Diego Internal Medicine Residency Program for the opportunity to conduct 2 months of dedicated research during a busy training period that is really unheard of and has really helped me to get into this research. So I now open it up to any questions that you all have.
Dr. Sampath-Kumar, thank you for that outstanding presentation. Really very impressive work. The first question is from one of your colleagues, Dr. Ann Xing. What amazing and fascinating research. Which phase of respiration do we use to measure IVC diameter if we do point of care ultrasound ourselves?
Yeah, great question, Anne, and thank you for the positive feedback. So you want to measure it at end expiration. That's what is recommended by the Journal of Echocardiography. And you want to make sure that at end of expiration that the patient is not doing the Valsalva, because that would actually increase the IVC diameter that you're measuring. So just at relaxed end expiration.
Thank you. From Dr. Klein, Spectacularly wonderful research and presentation. Did you determine the number of patients who could not have a reliable IVC measurement because of technical issues? Do you know how many of your heart failure patients had a sleep apnea by history?
Great questions. So just by way of the inclusion and exclusion criteria of the study, I only looked at patients that had an IVC diameter measured on the transthoracic echocardiogram. So the assumption is all those patients had easily visualizable IVCs. So I did not look at data on exactly how many patients we could not visualize the IVC on, but great point. And then to the second part of your question, I did look at a variety of past medical history, including smoking, COPD, but I did not look at obstructive sleep apnea specifically, but that's definitely something I would like to include in the prospective study.
And two more questions, Dr. Sampath-Kumar, from Dr. Mandel. Was the cutoff value hypothesis driven or derived? How much variability is introduced by patient size?
Yeah, so great questions. The cutoff value was derived using the Uden index. So just looking at the greatest sensitivity plus specificity. So not clinically driven, but derived that way. And we definitely did find a correlation between IVC diameter and body surface area. But interestingly, in our analyses, when we adjusted for body surface area and tried to see if that was a better predictor for rehospitalization, it actually was not. So the true uncorrected IVC diameter is actually more effective than the corrected in terms of predicting rehospitalization.
Excellent. And a final question from Dr. McGuire. Amazing job, Dr. Sampath-Kumar. I might have missed this, but how did you control for the confounding from the significantly increased rates of valvular heart disease in the rehospitalized group?
Yes, so there was significantly greater valvular disease in those that were rehospitalized, but even when we took that out of the picture, IVC diameter was still an independent predictor significantly. So even when we adjusted for that in our statistical analyses.
And one more question from Dr. Tai. Great presentation and high impact research. Maybe you have mentioned this, but did you see a difference between HFpEF versus HFrEF patients? Thank you.
Great question. I actually have like a full table in our paper that we're going to publish, but I did look at separated by HFpEF and HFrEF, and in our study, they actually had the same readmission rates, and among those patients, they had similar IVC diameters, whereas when we looked at jugular venous pressure, it was more likely to be seen in patients with HFrEF than HFpEF. So IVC diameter may be used across both of those.
Outstanding. Thank you again, Dr. Sampath-Kumar, for this just really impressive presentation.
Thank you, everyone.
Well done.
Thank you, Dr. Jassel, for everything.
And now, Dr. Fuentes, can I have you go ahead and share your slides?
Yeah, absolutely.
Perfect. It's my pleasure to introduce our second presenter, Dr. Ana Lucia Fuentes. Dr. Fuentes received her undergraduate degree, a Bachelor of Science in Biochemistry from Loyola Marymount University. She then completed her MD at the Rutgers Robert Wood Johnson Medical School. As an undergraduate, Dr. Fuentes was an NCAA Division I athlete and was an Athlete Scholar of the Year for all 4 years of college. We were so fortunate to recruit her to our internal medicine residency program, where she has been a remarkable member of our team. She's going to be presenting today on her research on neutrophil extracellular trap formation increases with COVID-19. Thank you, Dr. Fuentes.
Thanks, Dr. Jassel, for that awesome and super kind introduction. So as you all know, my name is Ana Lucia Fuentes. I'm one of the second-year medicine residents here at UCSD, and I'm really excited to be here today to present to you the research that we've been working on, looking at peripheral neutrophils in patients with COVID-19. So I have no disclosures to report to you, but I'd love to start off this talk by going over a little bit of background and terminology on what I'll be talking about. So I'm going to be talking a lot about NET and Netosis. NETs are these neutrophil extracellular traps. Basically, they're these extracellular DNA complexes that are made up of histones, nucleic acids, and proteins, and they're released during neutrophil cell death. The process by which these NETs are released is called Netosis. And the reason I want to talk to you about them is because they play a huge role in our innate immune system. So NETs and Netosis actually help us defend against many different types of microorganisms, including fungi, viruses, bacteria, and protozoa. And the way Netosis works is really through two main pathways. The first is called conventional Netosis. And the way it works is that this signaling cascade is going to be activated by the binding of different microorganisms to these toll-like receptors on the neutrophil cell wall, which is depicted here. This is going to lead to this increase in calcium release from the endoplasmic reticulum. And then that in turn is going to lead to increased activity of this protein kinase C or PKC, which is going to allow for the formation of FOX, which in turn is going to allow for the production of reactive oxidative species or ROS. And ROS basically then allows for the breakdown of this nuclear envelope. And then the contents within the nuclear envelope, including DNA and proteins, are going to allow for the formation of NETs. So when these NETs are ready to go, they're released through neutrophil lysis. And then they go off and fight off many different microorganisms. And the way they do that is through a couple different mechanisms. One is through entrapping the different microorganisms and basically preventing their spread throughout the peripheral body. And then the other way they do that is through their direct cytotoxicity. And that's super cool because they can go off and kill these bacteria directly. Meanwhile, this neutrophil that was lysed here is basically no longer functional and then gets cleared by the immune system. The second pathway by which Netosis occurs is called vital Netosis. And this is actually more recently discovered. So the exact steps of the pathway are not 100% clear. But what is known is that these microorganisms actually bind to platelets first. And then these platelets are going to bind to the receptors on the neutrophil and activate the pathway in that way. Ultimately, the end result is really similar. We have this production of the NET. But once this NET is ready to go, instead of having the release of it be through neutrophil lysis, you actually have it released through either blebing or vesicular exportation. And what's super cool about this pathway is that this neutrophil that's left behind is anuclear, but actually still functional. So it can go off and still chemotax and phagocytose and basically be a useful member of our immune system. Meanwhile, these NETs go off and basically help us destroy these different organisms. So now that I've talked to you about how great NETs and Netosis is, I'd like to shift over to the negative aspect, because unfortunately, too much of anything is not going to be good. And this overabundance of Netosis and neutrophil activation has actually been associated with inflammatory conditions. So specifically, overabundance of Netosis plays a role in autoimmune diseases. So if we look at ANCA-associated vasculitides, we know that there's these ANCAs or autoantibodies that bind to self-antigens or these proteins, specifically proteinase 3 or PR3 or myeloperoxidase, MPO. And this basically leads to this autoimmune response. Now in this vasculitis, you also have this increase in neutrophil stimulation and you have this NET release. When these NETs are released, you also have the release of these proteins, MPO and proteinase 3. Essentially, we're creating more antigen for which the autoantibodies can bind to, and then potentiate the autoimmune response. Nets also play a role in lupus, and the way they play a role is because neutrophils are hyperactivated, so there's just more net production in lupus patients. On top of that, these lupus patients have a harder time clearing the nets, so they tend to hang around the periphery a lot longer and then cause inflammation and damage in that way. And then finally, nets also play a role in rheumatoid arthritis, and this role is similar to that when we compare it to the ANCA vasculitis. And the way it works is that when nets are released in rheumatoid arthritis, there's this release of citrullinated protein, which again acts as another antigen by which the autoantibodies that are produced in rheumatoid arthritis can bind to. And again, this promotes this autoimmune response. Nets also play a role in our vasculature. Increased net formation has actually been associated with increased rates of deep vein thromboses. And the way this is thought to work is that these nets basically act as a scaffold. So these platelets actually bind to the net itself. And then there's this activation of these prothrombotic factors that actually end up leading to these clots. Nets also play a role in sepsis and have shown to worsen multi-organ failure. And the way this occurs is thought to be through multiple different mechanisms. The first is vaso-occlusion, which I just talked about through thrombosis, and this is thought to potentially cause end organ damage. The second is through endothelial dysfunction, leading to increase in inflammation and SIRS response. And then lastly, nets have been associated with cytotoxicity, which again is great when we're talking about microorganisms, but not so great when we're killing off our healthy cells. And finally, I'd like to talk about the role that nets have in acute respiratory distress syndrome, or ARDS. So ARDS, as we know, is this very severe lung injury that's really characterized by this acute hypoxic respiratory failure and this non-cardiogenic pulmonary edema. The most common cause of ARDS is infection, but certainly can be caused by other things like trauma, high pressure ventilation, and aspiration. And the pathophysiology of ARDS is really cool. So if you look at this figure here, you first see that there's this endothelial dysfunction that leads to the increased permeability of the capillary alveolar membranes. And then you have this acute inflammatory response, of which neutrophils play this huge role. So you can see that the neutrophils are migrating to this area of inflammation. They get through the membranes and end up in the alveoli, and then they perform their function. So you see that they can go about and do their respiratory bursts, they go off and degranulate, and then they certainly produce nets. And this leads to even more inflammation. Eventually, it will cause pulmonary edema, this impaired oxygenation, and this hypoxic respiratory failure. And the reason why I wanted to go into a little bit of detail about ARDS is because it allows me to shift over to the second part of our research, which was looking at patients with COVID-19. So as we all know, COVID initially emerged in December of 2019, was officially declared a pandemic in March of 2020. At the point of this talk, it's now responsible for about 590 deaths in the United States and almost 3.5 million deaths around the world. And at this point, it's plagued our lives pretty much every day since December. Now, we know that these patients with COVID-19 tend to have these dysregulations in their immune systems. Specifically, we see this profound neutrophilia and the significant lymphopenia in these patients. And one of the most feared complications of COVID-19 is actually ARDS, which I just talked to you about. And the reason why this is such a concern is that patients with COVID-19, their number one cause of death is actually ARDS. So now that I've talked to you a little bit about nets, a little bit about netosis, and also COVID-19, I'd like to present to you the hypotheses that we came up with. So knowing that that COVID-19 leads to this immune system dysregulation, this neutrophilia, and can certainly lead to ARDS, we hypothesized that the pro-inflammatory states that we see in COVID-19 would ultimately lead to increased neutrophil activation and increased rates of netosis. We also hypothesized that this increase in netosis would correlate directly with disease severity. So let me walk you through how we went about testing these hypotheses. And there's going to be two main parts of our methods. The first part was how we isolated the neutrophils, how we quantified netosis, and how we visualized our nets. But first things first, we had to recruit our subjects. So we ended up recruiting 21 human subjects with diagnosed COVID-19. And we did this with the help of our pulmonary critical care faculty and fellows. So once we had recruited these patients, we were able to draw peripheral blood samples from each of them at different time points. And once that was complete, we're able to go about and isolate our neutrophils. So the way we did that was by using this compound called polymorphoprep. If you look at this first test tube, you see two different colors. The blue is going to represent the polymorphoprep. The red is going to represent the peripheral blood. So we mix them together, centrifuge them for 30 minutes at 35 degrees Celsius. And basically this allowed the peripheral blood to separate into its different components. So as you can see here in this test tube again, the red at the bottom of the second test tube represents the red blood cells. The yellow at the top represents the plasma. And this neutrophil is this small layer right above the bottom blue layer, which is where the granulocyte layer is. And we're able to pipette out that layer, which is where our neutrophils were. So once we had isolated our neutrophils, we're able to start performing our assays and basically quantifying netosis. And the way we went about doing that was by plating these neutrophils in these 96 well plates. We then treated them with two different compounds, PMA and nigiricin. The purpose of these compounds is really to stimulate net production. We also had sets of neutrophils that were not treated with either of these compounds. The purpose of that was to see what netosis looked like without any stimulation at all. So once we did that, we incubated these neutrophils for 2 hours. We then treated them with a nuclease and EDTA to extract the extracellular DNA, which is where the net is. And then we treated them with this Pico green DNA kit to allow us to visualize and quantify using a fluorescent plate reader. So that's how we went about quantifying netosis. We also wanted to visualize our nets, and we did that in a very similar way. We plated our neutrophils. We again treated them with either PMA, nigiricin, or neither of those two, waited 2 hours, and then stained them for MPO and DNA. We were then able to visualize them with fluorescence microscopy and came up with these super cool images that I'll be able to show you in a little bit. Okay, and now to the second part of our methods, which is really determining the disease severity. And the way we did that was by using Apache 2 scores. So Apache 2 is basically this scoring system that we use in our ICUs and is used in ICUs around the world. The reason we use it is because it's a mortality risk score, and it basically allows us to risk stratify patients. So Apache 2 takes into account 12 different physiologic variables, which I listed out in the table below. And then it also takes into account patient age and chronic health conditions. So you basically take all of these factors, plug it into this algorithm, and you come up with a score, so that the higher the score, the sicker the patient is. So again, we calculated out this score for each of our patients at the time points at which the peripheral blood was drawn. Once we had that, we were basically able to analyze our data using linear regression and compare our different variables, including Apache 2, netosis, as well as absolute neutrophil count. Okay, now I'd love to show you some of the data that we collected. So first, I want to show you how peripheral neutrophils in our COVID-19 group ended up producing more nets than the healthy controls. So this is the first graph I have for you. On the x-axis, you see the concentration of PMA. In this case, it's 0. On the y-axis, you have net quantification, or the fluorescence. And we have two different categories here. We have the blue category, which is our healthy control group, and we have the red category, which is our COVID-19 group. Each of the dots represents netosis at a different point in time. Now, as you can see here, the control or the COVID-19 group had a statistically significant higher rate of netosis when we compared it to our healthy control group. And this was done under no stimulation at all, so at 0 PMA. At this point, we also wanted to see whether we could induce even more netosis. So we ended up treating with different concentrations of PMA, like I mentioned in our methods. So here's the rest of our graph, and you could see that there's a little bit of an increase in the rate of netosis as the concentration of PMA goes up in our control group. But you still see a higher rate of netosis in our COVID neutrophil groups at every single concentration of PMA. And again, this was statistically significant throughout all of these concentrations. Now I'd like to show you what we see using our fluorescence microscopy. As promised, this is what the visualized nets look like. The myeloperoxidase staining is green and the DNA staining is blue. And the more lit up that you see the image, basically the more nets that there are. So you can see that at the 3 concentrations I have here of PMA, you see a lot more blue and green lit up in our COVID-19 groups. This means that there's more nets present in our COVID-19 neutrophil group when you compare it to our control. And this is very consistent with the graph that I just showed you. Okay, moving on, I'd like to show you some data on how netosis compares with disease severity. So you see this graph here, and we have an x-axis with 3 different categories: our control group, Apache 2 scores less than 15, and Apache 2 scores greater than 15. On the y, we again have fluorescence or net quantification. And you could see here that our sicker patients, as measured by higher Apache 2 scores, had higher rates of netosis when you compare them to the other 2 groups. We saw a similar thing through this linear regression graph. So you see that as the Apache 2 score goes up on the x-axis, the rate of netosis also goes up on the y-axis, and you see a positive correlation here. And finally, I'd like to show you the association we found between netosis and absolute neutrophil count. So I have 2 graphs to show you here. On the x-axis, both of them have the absolute neutrophil count, or the ANC. On the y-axis, both of them have fluorescence, or the net quantification. And you could see that there's a strong positive correlation in both, so that as ANC goes up, so does the rate of netosis. The difference between the 2 graphs is that the graph on the left, or the red graph, is under unstimulated conditions, again, not treated with either compound. And the graph on the right, or the blue graph, is actually stimulated by nigiricin. Okay, so overall, we have a few main findings from the data that I just showed you. 1, we saw that there was increased netosis in patients with COVID-19 when we compared them with healthy controls. 2, we saw that patients that had higher Apache 2 scores had higher rates of netosis. And 3, we saw that patients that had higher ANC also had these higher rates of netosis. And this allows us to make several conclusions. The first confirms our initial hypothesis that patients with COVID-19 had more hyperactive neutrophils than healthy controls. And the reason we know that is because COVID-19 neutrophils ended up producing more nets, both in stimulated and unstimulated conditions. Our second conclusion confirmed our second hypothesis that increased netosis actually correlated with disease severity. And this was using Apache 2 as a measurement of disease severity. Now, in the beginning of our study, we were hopeful that netosis would be a good biomarker for disease and might help us in terms of risk stratification. Unfortunately, after doing a lot of this work, we realized how time-consuming these assays were and perhaps not super practical in the real-life setting or in the clinical setting. But luckily, we have this third conclusion that we saw this positive correlation between ANC and netosis. So we're really hopeful that this absolute neutrophil count could be a good prognostic marker and be the biomarker that we were looking for. So once we finished this research project, we ended up with a lot more questions that we wanted to answer, which is typical of our research in general. So the first thing we would like to do in the future is really determine between this we really want to determine if this correlation between ANC and netosis also exists in healthy individuals. We suspect that this correlation might only exist in sicker patients with inflammatory conditions. We'd also like to take a look at whether targeting netosis would actually help prevent the progression of COVID-19. And it would be interesting to see that if we stopped netosis or neutrophil activation too early on in the disease course, if this could potentially actually worsen disease state or lead to superimposed infections, seen as we'd be blocking part of our innate immune system. And lastly, we would love to look at the relationship between netosis and disease severity in multiple other disease states, including other causes of ARDS, patients on ECMO, other viral diseases like influenza, and then certainly many different SIRS states. So at this point, I'd love to thank everybody that helped me with this presentation. Special thanks to my mentor, Dr. Crotty Alexander. She helped me with this presentation, with my research year, and has given me awesome life advice in general. Dr. Jorge Massa Silva, who did a lot of the heavy lifting in terms of the bench work and then the neutrophil assays. Dr. Kufa and Dr. Lamb, who had the initial protocol, and then Dr. Meyer, who had her neutrophil expertise, and then everybody else on the team that basically was super important in my research year and for this project. So at this point, I'd love to take any questions that anybody might have for me.
Dr. Fuentes, thank you so much for sharing that incredible work with us. And I don't know if I mentioned this at the beginning, but Dr. Fuentes is also one of our second-year residents. So truly an amazing accomplishment that our residents have been able to do this. Sorry, I apologize. I just wanted to say thank you for this, sharing this incredible work with us, Dr. Fuentes. Dr. Fuentes and Dr. Sampath-Kumar are both second-year residents, and I think it's just so impressive that they have been able to accomplish this work during an incredibly busy and demanding clinical training. Dr. Fuentes, the first question is from Dr. Mandel. Beautiful work. Are there specific types of infection that evoke a greater netosis response and ones that evoke less of one?
Yeah, so looking through the literature, it seems that the higher rates of netosis are associated with bacterial and viral diseases. I think one of the greater rates of netosis is actually associated with Staph aureus. And the reason they think that that's true is because it uses both pathways, vital netosis and conventional netosis. Vital netosis happens first and then conventional netosis happens second. So they've seen that initially.
And from Dr. McGuire, incredible that you did this lab research during residency, Dr. Fuentes. With all of the recent concerns about COVID and clotting, have you thought about looking at complement levels and/or markers of hypercoagulability in the elevated netosis and COVID group to see if there is an association there?
Yeah, I think it'd be really cool to look at complement levels. I think that's definitely part of the next steps that we'd like to take a look at. With this particular project, we had a little bit of a smaller sample size with only 21 patients. I think it'd be really cool to kind of expand that and look at clots as well as complement levels. And I know we were looking at cytokines as well. So definitely part of future plans.
From Dr. Rubin, the non-replicating adenovirus vectors associated with the AZ and the J&G vaccine, AstraZeneca and Johnson & Johnson vaccine, are provided at a very high titer. Are there any patients that have had an untoward response due to activation of this pathway?
I don't know. I'm not sure about that. I know we didn't look at that specifically. It would be interesting to look at the rest of the literature to see if anybody's looked at that question specifically, but definitely interesting.
Well, I want to again thank our two presenters, Dr. Sampath-Kumar and Dr. Fuentes, for sharing this really remarkable work with us. We're so grateful to you and so proud of you. Thank you all for joining us today, and please log in next week for Department of Medicine Grand Rounds. Have a great day.
Thanks, Dr. Jasso. Bye.